This podcast is supported by Americans for Medical Progress and was founded and created through the Michael D. Hare Fellowship, awarded annually to support projects that inform and educate the public about the critical role of animal research in furthering medical progress. The fellowship honors the late Dr. Michael Hare, a renowned board-certified laboratory animal veterinarian who dedicated his career to scientific and medical advancements and who was deeply committed to animal welfare and advocacy. Hey everyone, and welcome into this episode of Lab Rat Chat. Today we're doing something a little bit different. We are interviewing a laboratory animal veterinarian, as we have done in the past, but we also have her husband, Cody, and we've been talking about doing this before. I don't know if we've talked about it on the podcast or not, but we wanted to highlight some patient stories. So people that are living with a condition that maybe is something that is highly researched and has applications for treatments through biomedical research, and it's something that's evolving. And today we have Rebecca and Cody, who has cystic fibrosis, and he's going to tell you all about that condition and the background information and some of the research that's going on. And so it's kind of a cool dynamic having Rebecca, who's the lab animal vet, and then Cody, who's has cystic fibrosis, and that dynamic. And so I think it'll be really interesting for you all to hear their perspective on this and hear, maybe Cody's perspective on laboratory animal research and Rebecca's perspective coming from, more of the science aspect and being a veterinarian and working with non-human primates and other species that may or may not have been involved directly with research for Cody's condition. So I don't want to say too much. I'll let them introduce themselves. I thank you guys both. I really appreciate you guys, Rebecca and Cody, for coming on and talking to us today. It's been difficult to try to get people to come on and tell their stories, but I think it's something we talk about transparency, and just this really highlights the importance of biomedical research, just talking to people that, have the potential to be directly impacted by the research that's going on. So thank you guys for joining us today. And if you would, just go ahead and tell us a little bit about yourselves. Whoever wants to go first, Rebecca or Cody, go for it.
Yeah, I think I'll get us started. And thanks for having us on. We really appreciate this opportunity. So as you said, I'm a lab animal vet. I'm one of those people who always knew they wanted to be a veterinarian. I just didn't really know what kind of vet I wanted to be. So I went to veterinary school at the University of Georgia, and I started off on a mixed animal track. I'd had very little exposure to research before vet school, and I was introduced to lab animal medicine in my first year. It seemed really interesting to me, and at the encouragement of a mentor, I began to explore the field. After a year or so, I was sold. I just really loved the idea of getting to help with life-changing research while also being an advocate for the animals and getting to work with all the different species that I enjoyed working with when I was mixed animal. So I changed my track to public corporate, which was just kind of a catch-all for all of us that weren't going into private practice. After vet school, I moved to Houston, and I did a 3-year residency in lab animal medicine, and I met Cody during that time. We got married a few weeks before I finished my residency, and he had a really good job in Houston, so moving would have been difficult. Fortunately, a position opened up at a contract research organization in Houston, working with non-human primates. And then after about 2.5 years with them, I was ready for a change. So in September, we moved from Houston to Morgantown, West Virginia, so I could start a new job as a clinical veterinarian at West Virginia University.
My name's Cody. I'll give my background. Rebecca's husband. I'm 30 years old and I have cystic fibrosis. And a little bit about me. I grew up in Texas, moved to Houston after graduating from college, where I majored in mathematics. I moved to Houston to start a job as an actuary at a life insurance company. Right now, I'm focused on universal life valuation and financial reporting. And prior to COVID, I was really into board games. But obviously, during COVID, it's not quite as easy to get a group together.
Yeah.
And yeah, now that we're in West Virginia, I'm excited about being closer to the outdoors, doing some hiking and snowboarding. Yeah, that's a little bit about me.
Have you had luck with working from home kind of because of COVID? I know you guys just relocated to West Virginia, but Rebecca mentioned you had a really good job in Texas. Were you able to keep that and work from home, or did you have to find something else?
Yeah, fortunately, with everybody going to work from home during COVID, that made it a lot easier. And we had people in a bunch of locations already. It just wasn't quite as normalized. But I think now, yeah, it's made it so much easier to make that transition.
Excellent. Yeah. Could you guys maybe give our listeners some background information on cystic fibrosis? I know personally my knowledge is fairly limited, so this is definitely going to be very informative for me too.
Yeah, I'll start off since I'm the person with CF here. So starting off, CF is a multi-system genetic disease. It's pretty rare. It affects about 30,000 people in the United States and about 70,000 worldwide. It's caused by a recessive gene, and it's kind of a classical recessive disease. So if both parents are carriers, there's a 25% chance of their child having the disease. And CF is most often diagnosed at birth or really early in life. About 15% of infants have a birth complication called meconium ileus. I was one of the lucky 15. The golden standard diagnostic tool is a sweat test. Babies with cystic fibrosis people with cystic fibrosis throughout their life have high levels of chloride in their sweat. And that's because cystic fibrosis, the kind of key component of the disease, is a dysfunctional CFTR protein. And that protein is responsible for moving chloride to the cell surface where chloride would attract water. So without enough chloride, mucus is too viscous. And that's the underlying problem with CF. And that's why it affects so many organ systems. So then some stats before I get into the rest. About 1 in 25 to 30 Caucasians are a carrier of the cystic fibrosis gene. And about 1 in 4,000 to 10,000 Latin Americans, 1 in 15,000 to 20,000 African Americans. And it's even less common in Asian Americans. So it means that there's not a lot of non-Caucasians with CF. And unfortunately, those that kind of do have it are sometimes diagnosed later in life because doctors don't necessarily consider the possibility for kids that have CF. So I'll give a little bit of background about kind of each of the organ systems that are involved, and then I'll turn it over maybe to Rebecca to do some more. So starting off, the lungs are the most kind of affected organ system. And the big deal here is that there's a mucus problem. So thick mucus secretions are really difficult to clear, and they allow colonization and overgrowth of normal human flora. Most common, that's Pseudomonas or staph. And there's a couple of other possibilities that are a little bit worse, but kind of rarer. Those are Burkholderia cepacia and non-tuberculosis mycobacterium. And when these bacteria overgrow, CF patients have to go on antibiotics to fight that infection. And so one of the kind of typical things that'll happen as part of that therapy is after a couple of years of antibiotic use, strains of those bacteria can become resistant. So leading to, multi-drug resistant Pseudomonas or MRSA. And kind of the other complication with that bacterial infection is it causes inflammation in the lungs, which will cause scarring in the airway. And that is what ultimately leads to loss of lung function. And that loss of lung function is kind of the sort of long-term big complication with people with CF. So the other kind of bigger organ system that's affected is the pancreas or really kind of GI. So with the pancreas, mucus blocks secretions of pancreatic digestive enzymes, and it leads to fibrosis or scarring of areas of the pancreas that secrete these enzymes. And in the intestinal tract, that thick mucus can affect the movement of ingesta through the intestines, leading to a potential for blockages. Some CF patients have gallbladder disease, liver disease, and another kind of normal complication that can develop is cystic fibrosis related diabetes, which is a lot more similar to type 1 diabetes. And that happens when the beta islet cells of the pancreas become damaged. And then I think the last big thing is reproductively. With men with CF, about 97% of men are infertile due to congenital absence of the vas deferens. And most women with CF are able to conceive normally, but they might have to, consider some health, complications during pregnancy. But that's a little bit of background. And I think Rebecca's got a little bit more to share.
Yeah, so I wanted to touch on some of the mutations to that CFTR gene that can cause CF. So there are actually 1,700 mutations to the CFTR gene that are known that can cause CF or CF-related symptoms. So some of these mutations are more severe than others, but the CF experience is still very individual. So two people with the same mutation can have very different looking disease. These mutations are classified into one of 5 classes, and these classes are really important when it comes to creating targeted therapies for the patients. So class 1 mutations are protein production mutations. This includes nonsense and splice mutations, and these cause the cell to not be able to make a correct CFTR protein. Then class 2 mutations are protein processing mutations. After a protein is created, it has to be folded into a 3D shape in order to carry out its function. So the CFTR protein's function is to transport a chloride ion. So even one incorrect amino acid in the protein can cause the protein to not fold correctly. And this is the case of the delta F508 mutation, which is the most common mutation of CF, and it's also the mutation that Cody has. So he's homozygous for delta F508, which means that both of his copies of the CFTR gene carry that mutation. Other mutations in this category can cause decreased levels of protein at the cell surface or just decreased functioning. Class 3 is another pretty common class of mutations, and those are gating mutations, which means that the CFTR protein, the shape that it makes is a tunnel or a channel with a gate. And the cell can open this gate to allow chloride to flow through the channel. With these mutations, the gate stays closed, so chloride can't get through. We'll get into therapies and drugs related to CF later, but the first of a new class of CF drugs called CFTR modulators target this type of mutation, and they help the gate to stay open. Class 4 mutations are conducting mutations. In these, there are changes to the inside of the ion channel that cause chloride to not flow through as it should. And then class 5 mutations are insufficient production mutations. These cause a reduced amount of normal CFTR protein on the cell surface, either because not enough is made or because it degrades too quickly.
I think that goes back to all the research that's been done. I mean, just being able to know all that information is pretty incredible. And I feel like I'm also studying for midterms right now. I'm feeling a little bit of anxiety with all the classifications going on because we're learning a lot about different diseases and I have to memorize those classifications. So as long as there's not a test at the end of this podcast, I think we'll be good.
Yeah, it kind of throws back to like if anyone took an intro bio class, maybe in college, when you learn about proteins being made and how they have to fold and everything, it can get a little complicated, but it's so important with like understanding how CF happens.
Yeah, for sure. And it's especially to be able to do research and then target therapies towards, potentially treating or curing the disease, which you said we'll talk about a little bit. So anyways, Cody, I think you're going to give us a little bit of history about cystic fibrosis and some of the research or treatments that are out there. Is that right?
Hopefully going through the history, we'll get through, when this research on all of the mutations kind of came to the forefront. So starting off, I think this is interesting. I was born in 1990, so keep that in mind going through this timeline. So the timeline begins in 1989. So that was when the defective CFTR gene was discovered to be the cause of cystic fibrosis. 1 year later, researchers discovered that gene therapy was a potential possibility. I think it was a kind of a proof of concept study that proved that gene therapy could be used to treat CF. And so moving through the 90s, kind of two important drugs were approved by the FDA. The first is called Dornase alpha or Pulmozyme, which helps to thin mucus in the lungs. And it was the first drug developed specifically for CF. And the FDA also approved inhaled tobramycin, which was the first aerosolized antibiotic designed for CF, which is proven to reduce hospital stays and improve lung function. So now we kind of enter the 2000s, and early in the 2000s, one of the other kind of more important, what do you call this, basic science, I guess?
Yeah. Microbiology.
So scientists mapped the entire genetic structure of Pseudomonas aeruginosa, which is the most common cause of bacterial lung infections in CF. So a really important bug to understand in order to help to treat people with CF. So then next, there was a clinical study that showed that the antibiotic azithromycin helps to improve CF lung function. And the next big one, which I have a quick story about this, is there are studies in Australia and at the University of North Carolina that showed that inhaled hypertonic saline helps clear CF mucus and improve lung function. And that became a therapeutic option. So my quick story, whether this is like complete apocrypha or not, I don't know. I just heard it from a respiratory therapist one time. I think the story goes that the impetus for discovering that inhaling hypertonic saline was useful was because in Australia, they noticed that CF patients that lived near the coast and surfed had better experience than those that didn't. So then they kind of clued in that like maybe there's a reaction where that sort of ingestion or presence of salt is helping to then move water into the lungs. And that was the whole impetus behind kind of beginning that research. At least that's what I'm told.
Huh.
I like that theory. Yeah.
So did you try picking up surfing to see if it helped?
I surfed a little bit as a kid.
Yeah.
Maybe not enough.
Yeah.
Okay. Maybe not in Australia. Maybe it's different air there, you know?
Exactly.
That's the key is you got to get to Australia.
Yeah. Okay. So now we get into the more genetic aspects. So this is kind of later into the 2000s and it'll kind of lead us into today. In 2006, ivacaftor, which was an oral drug, was started to be developed, which targeted the faulty CFTR protein. Entered clinical trials in 2006. So that drug was designed to open the chloride channels that don't function correctly in people with CF. In 2008, a similar drug, the same drug, ivacaftor, entered phase 2 studies. And so specifically, this one was going to target people with cystic fibrosis that have the G551D mutation. And during those phase 2 studies, it showed unprecedented improvement in key signs of the disease, which is a proof of concept for kind of the whole CF community and the research community around it, that this was a possible treatment to treat the root cause of CF. In 2010, one of the next major improvements was a new antibiotic called Aztreonam or Caistin was approved to treat CF lung infections. It's also inhaled like tobramycin. And so this drug offered kind of an alternative for people with CF who develop resistance to existing antibiotics. And so I'll get into this later, but once this antibiotic kind of entered the treatment regimen, it then became common for people with CF to cycle those two inhaled antibiotic drugs. So you do a month of tobramycin and then a month of Caistin and just cycle those on and off. That cycle, at least for some people, is enough to prevent, resistance to either drug happening quite as quickly. So then kind of more on the CFTR kind of modulator drugs. In 2012, the FDA approved ivacaftor or Kalydeco, again for the G551D mutation. And so that was the first drug that treated the underlying cause of CF. In 2014, the same drug, ivacaftor, was approved for 9 more mutations. So that got us to about 8% of the CF population. In 2015, the FDA approved lumacaftor/ivacaftor, which was a combination drug called Orkambi. And that was now targeted for people with 2 copies of the most common mutation, the same one I have, F508 delta, which represents about 1/3 of the CF population. And then in 2017, there were 2 phase 3 clinical trials for another combination therapy, which then moved to expanding the population who could take the drug to people with CF with 1 of 23 residual function mutations. And then kind of moving all the way to the present in 2019, Trikafta, which is a triple combination of the drugs in Symdeko plus Alexacaftor, was approved for CF patients 12 and older with at least 1 copy of F508 delta. And so that represents about 90% of the CF population. So
that's quite the progress that's been made. I mean, almost every year since 2000, there's been a pretty, substantial new discovery or drug or something that's come out.
Yeah, especially as somebody with the disease, it's been incredibly encouraging that, honestly, probably every 12 months I can go, to an appointment with my doctor and there's like something else on the horizon. I think one thing that is cool is it's extremely encouraging for people like with the disease to know that the research community is constantly at work.
You're right in that aspect. But I think at the same time, I would have to, because when I was in college, I think it was probably like that 2008 study you talked about. And they had basically at that point, like my instructors were talking about how cystic fibrosis is basically going to be cured in the next few years. So I think at the same time, it's probably a little frustrating at times too. Like people keep telling you like, hey, right around the horizon, we're going to have this cure or this amazing life-changing treatment. Maybe some of that's true and you get a new treatment, but it's not everything you thought it was going to be. So I don't know. I could see there being going both ways. Yeah, it's amazing that there's this amount of research going on, but at the same time, there could be just some frustrations a little bit at times too with the level that people take the research, saying a cure is around the corner kind of thing, which maybe you don't experience that. I mean, obviously I have a different perspective. I just learned and heard about it from my professors in school and stuff like that.
No, for sure. And I think speaking for like the wider community, I think there's definitely a portion of the community that, as I pointed out, almost at the beginning of that timeline, even if we go back all the way to 1990, that's when scientists knew that genetic therapy was a possibility. That the goal obviously is a cure. And I think it's been tantalizing and frustrating for a large part of the community that a genetic cure is a possibility. It's just that the science behind getting it to work has continued to frustrate everyone.
All right. Rebecca, I think you wanted to talk a little bit too. I think you had some information for us just in general about some life expectancy and then some improvements in that life expectancy that's occurred over the years.
Yeah, so we've kind of touched on this a little bit, but, CF historically was a childhood illness. I think we've even heard stories or saw a presentation on, it was somebody from like medieval times, and they had this, I don't know if it's not an old wives' tale, but they had this thing where salty babies they considered them cursed because they were doomed to die young. And now you look back at that and you're like, well, they probably had CF and they had no idea what it was then. So, the babies didn't live very long. So historically, CF was a childhood illness and many patients died by the age of 5. When Cody was born, the life expectancy for someone with CF was about 30 years. And if you've done some math, plus I think he told you at the beginning, he is 30. So his parents were told to expect him to have a life of sickness and hospital stays. So now, if you look at the average life expectancy, it's probably about 40, but it's really important to realize that some patients live a lot longer and some patients live much shorter than that. I still hear stories of CF patients that die in their teenage years. And I also know of people who have lived into their 60s and 70s and are still doing really well. So, kind of going back to, it's a very individual disease and two individuals can have very different symptoms and experiences. But recent modulator therapies have helped a lot, and we're expecting to see drastic improvements in those numbers. So even just during the course of Cody's lifetime and everyone in our generation, there have been so many improvements that the narrative that his parents received when he was born is not the narrative that a parent would receive now if they had a child with CF. I mean, now a lot of these therapies are approved for young children, so they can go on Trikafta when they're 12 and may not experience much or any loss of lung function over the course of their lives. So now, also CF is characterized and is still characterized by frequent hospital stays, going on IV antibiotics, fighting bacteria that become resistant to common antibiotics, and then all of these recurrent infections cause scarring in the lungs and reduce lung function, which can limit a patient's ability to do normal life stuff. Cody has been hospitalized a few times in recent years to go on antibiotics. But now, because of these new therapies, patients are living longer. They're able to grow up, go to college, get married, have careers, have kids. There's more adult CF patients than children in the US right now. And they've also had to make, adult CF clinics. Those didn't used to be a thing because there just weren't that many adults that had CF.
Yeah.
But now, there's pediatric clinics. And then when you become an adult, you move to an adult clinic. And that's just part of the normal CF life now.
Yeah. I remember as a kid, the center that I was at when we were living in Austin, I saw a pediatric, I was seen at the peds clinic, basically all the way up until I was, in college. It's interesting.
And talking about, the developments that have led to an increase in life expectancy, what are some of those therapies that are currently available that, allow that increase?
Yeah, I think the most important ones, there's sort of almost 4 categories of improvements been really transformative. The first one are kind of 2 drugs that people with CF take daily. So that would be hypertonic saline and pulmozyme. And they're both help to thin the mucus secretions to allow patients to cough and clear that mucus out of their lungs. The second is kind of targeted antibiotics to kind of target the specific bacteria that grow and can be nebulized, so inhaled and go directly to the lungs. So those would be tobramycin and casein. Kind of the third one is kind of the discovery that azithromycin is helpful. And that one's a little bit different because the way that azithromycin is done is just taken orally as a pill. And so it's more like a prophylactic, I guess. And then the fourth class, the most exciting one, I guess, is these, newer CFTR modulator drugs. So Kalydeco or Orkambi, Trikafta, that improve the functioning of the CFTR protein itself. And that's been the real major advancement for me in recent years is the CFTR modulators. And to talk about my personal experience, when I started taking Trikafta in particular, I gained 10 or 15 pounds just due to like improved digestive absorption and I guess efficiency. My lung function improved significantly, and I've had less frequent issues with exacerbations. That's like within the CF kind of community. Exacerbations is the word we use for sort of an uptick in bacterial infection. There's kind of a knowledge that like there's, always bacteria in your lungs, but it's whether kind of that overgrowth has gotten significant enough to be causing issues. While that's like only my personal experience, I think a significant portion of the CF population has experienced similar gains. The experience is, of course, like by no means universal. And so kind of like, I talked to Jeff about earlier, the search for a cure is still the ultimate goal. And I think this is a particular point where I can plug the CFF or the Cystic Fibrosis Foundation. They're really the key advocate within the CF community. They're a nonprofit that, in addition to kind of advocacy and education, they fund research. I think if I'm remembering my numbers correctly, last year it was somewhere around 190 million in research grants alone. And so the foundation has been, I think it like literally every drug I touched on was CFF funded research. So they've been fantastic kind of partner in the CF community.
I was just going to say, we will include show notes for all of our episodes. So we'll make sure we include a link to the CFF website and people can go check that out. And I'm sure there's ways they're a nonprofit, make donations and things like that as well, if anybody's interested in that. And like you said, a lot of that money is going directly towards research. That with your extensive list you gave us earlier, with all the research, you see that there's lots of progress going on and lots of progress to be made still. So the more help they can get, the better it is for everybody within the CF community, and then everybody supporting those within the CF community as well. So
yeah, those are definitely the major kind of therapies that I wanted to talk really quickly about kind of what a typical day looks like for somebody with CF and like how those therapies kind of are actually used. I think I've touched on it a little bit, but kind of aside from the lungs, which will be the bulk of this discussion, a portion of the CF population that has pancreatic insufficiency. So they'll take digestive enzymes before every meal to kind of aid in digestion. And then moving on to the lungs, kind of the biggest part here. The goal with daily lung therapy is to treat bacterial infection and clear the airways to prevent inflammation. That inflammation of the small airways, I think in particular, leads to scarring of lung tissue and loss of lung function. So that's kind of the continual daily battle. So there's kind of an order of operations here, which is kind of interesting, but definitely critical. So this is sort of a kind of nebulized therapy kind of order for people with CF. So the first thing they would do is take albuterol sulfate nebulized. So it's a bronchodilator that opens up the airways. Second step is your kind of drugs that assist in mucus thinning and clearance. So it's hypersonic, saline, and pulmozyme. So that's going to help to thin mucus secretions. Third step is airway clearance. And so there's a couple of different things you can do here. I have a literal vest that I wear that vibrates and shakes me to assist in kind of breaking up mucus secretions. That can also be done like manually with chest kind of physical therapy. So kind of literally like beating on your back and your chest to do the same thing. And then there's a couple of devices. One's called a flutter. The other's called an aerobica. And what those do is you kind of blow into them and they create positive expiratory pressure. So kind of inflates the lung and gets a little bit more air in passages that wouldn't normally have it to, again, kind of try to thin and get the mucus moving. And then there's also a specific sort of coughing or huffing technique to try to clear that stuff out. So yeah, the next step after all of that is done, kind of after all that coughing and clearance, is an inhaled steroid. So that's going to reduce inflammation caused by therapy, reduce inflammation that's there anyway. And the whole idea here is to prepare the airway for the inhaled antibiotics that are your last step, because those can sometimes be irritating. And your goal, of course, before this has been to cough and get all that stuff out. But once you get the inhaled antibiotic in, you don't want to cough anymore. When you get that stuff in, you want it to lay down on the airways, and you're hoping that it'll stay there so it can, treat the infection and prevent kind of further infection. So that last step is your inhaled antibiotics nebulized. So that's tobramycin or Caistin to combat the bacterial infection. And like I kind of touched on earlier, typically this is cycled for 1 month on and 1 month off, kind of just moving between the two to try to prevent resistance. But yeah, thanks. I just thought it was, that would kind of be helpful to understand that kind of cycle.
Yeah. Just kind of gives perspective too of what you have to do all that basically, give or take the fifth one that you talked about, which you cycle every day. I mean, that's part of your daily routine, huh? So, I mean, it just takes a lot of, just so much, I think I would imagine time and effort on your part. Of course, it has to be done. So it's probably second nature to you and you've probably been doing it forever. But for people that don't, sometimes we're like, man, I don't have an extra hour of my day to give. And you guys do this every day.
Yeah, that's something Rebecca wrote these down on our kind of notes, and I hadn't put it there, which is probably a little bit telling.
For you, it's normal, unfortunately.
But yeah, it's about an hour of therapy twice a day. And you can touch on this, Rebecca, but I think it's something that we've kind of thought about. Every time that we, kind of like what you said, Jeff, every time that we hear about people talking about time management, not having enough time, it's really hard for us and maybe a little bit triggering sometimes because we think about how much we center our lives around this.
Yeah, for sure.
Yeah, just like it's time consuming. And then, I was talking about patients with CF have normal lives now. So we both have careers and, we don't have kids yet. We certainly would like to have kids in the future, but this just adds like one more massive thing that we have to deal with when we're trying to deal with everything else that other people deal with. And then just ordering medications and fighting with insurance and doctors and messaging and just trying to like stay on top of everything. It's a lot.
Yeah, even just something that like we probably take for granted, just like, oh, on Saturday I have to go to a wedding, which is from noon to 9 or whatever. It's like you guys probably have to plan around like longer events that you'd want to go to. That's something that I wouldn't even take into consideration.
Yeah, we definitely have to plan, back before COVID when we actually went to things like weddings.
Exactly, yes.
We had to plan, if we were going to be out late one night or up early one morning, occasionally we will skip a treatment. It's not great. Thanks to Trikafta, it's a little bit easier, but, you kind of got to balance it all. And then we traveled a lot. And when you travel, we've got the vest. We have a lunchbox with an ice pack for refrigerated meds. We have to bring a nebulizer or like we have nebulizers at our parents' houses. So when we travel, we don't have to bring a nebulizer with us all the time. We have to figure out a way to like sterilize nebulizer cups. And
I'm sure not everybody in the CF community can afford to do this, but that's been our strategy, especially with our parents living in different states. I have a nebulizer at each parent's house and at one of our parents' house currently. And we've discussed doing this with the other. We also have a baby bottle sterilizer that we use to sterilize all of my neb cups. So that way we have to transport less stuff every time we visit.
Yeah, for sure. Good thinking.
That's a lot. And TSA.
Yeah.
I'm trying to explain to TSA every time we travel.
I'm sure they give you quite the look. Yeah.
Yeah, they're usually not too bad, but usually we do have something get pulled. It kind of varies by trip what they do pull, but usually they'll pull aside something for extra testing.
Yeah. Well, Rebecca, being a show about primarily, animal research and, biomedical research, could you tell us just a little bit about how the use of animal models has contributed towards medical advancements for people living with CF?
Yeah. So I haven't had the privilege of working directly with any animal models of CF, but I did do some research on the subject because I thought you were going to ask me this question. So genetically modified mice strains are, of course, the most common models. For the large animal side, ferrets and pigs are commonly used. And these also are usually genetically modified so that they have the defective CFTR gene. All of these models have their own unique advantages and disadvantages, but together they have helped to greatly increase our understanding about the pathophysiology of cystic fibrosis. And that gives scientists ideas on how to develop these therapies and treatments, a lot of which we've discussed already. So there's a couple specific examples that I thought were really cool. One is concerning macrophages. So macrophages are immune cells, and these play a significant role in preventing bacterial colonization. So in the lungs, they basically eat bacteria. And through studies in mice, we learned that macrophages in CF lungs are unable to break down the bacteria that they internalize. So this significantly hurts a person with CF's ability to fight these bacterial infections. Like all of us have bacteria living in our lungs, but in CF lungs, the bacteria overgrow. So it was also discovered that CF lungs have abnormal cytokine levels, and cytokines cause inflammation. You've probably heard a lot about cytokines in relation to COVID-19 and causing inflammation in patients with COVID-19 that have very severe diseases in relation to that. With pigs, pigs have helped us understand when bacterial colonization and these abnormalities in the lungs first happened. So there's a bit of a chicken and the egg debate with CF about what happens in an infant first, whether it's the bacterial colonization or inflammation. Because when a baby is born with CF, their lungs look pretty normal. So, we kind of need to figure out what kicks off this cascade so that maybe you can stop that from happening. So pigs have also helped us understand how this cascade of infection and inflammation starts, which then can help us develop therapies to try to stop it.
Yeah. A quick question for Cody, kind of doubling back. I know before we scheduled this recording in our little prep talks, you had mentioned that you had involvement in one of the clinical trials for a therapeutic that was discovered to be beneficial through the use of animal research. Is there anything you can kind of tell us about that?
Yeah, I was lucky enough back when we were in Houston a couple of years ago. I was part of the phase 3 trials for the drug that would later go on to be named Orkambi. I think for me, it was interesting to kind of be part of the trial. Like most of the data was like normally collected from my physician. So I think the only other thing I had to do was just like more blood draws, which I've gotten used to. I think it was really interesting for me to actually be part of a study. But other than that, it was kind of just normal life, like taking the drug. I guess the other one that I kind of want to highlight that's a little bit different, just another plug for the CFF, is one of the important kind of tools for researchers at a kind of macro level is the CFF maintains a national patient registry with clinical data and treatment history. So that can be leveraged in kind of long duration population studies for people with CF. And I guess with Orkambi or kind of some of these other drugs, we don't know for sure what animal models were used or what animal research was done to lead to these discoveries. But, we obviously know that animals contributed from early drug development all the way to preclinical safety testing.
Yeah, for sure they did. Real quick, before you met Rebecca, or maybe growing up, just thinking about animal research and the involvement the animals have in, all these therapies, did you have a certain take or view or opinion on animal research before you met Rebecca, or has that changed since you met her, being obviously a live animal vet working with animals?
Yeah, I'm glad you're asking. I definitely knew that animals were used in research. I think that prior to meeting Rebecca, I definitely didn't understand the prevalence of animals being used in research. And I think at the same time, because I didn't understand how, maybe this is the chicken and egg thing, I didn't understand the prevalence. And I think I also did not understand the importance. I think for me, there was a lack of understanding of how critical they are to research. And at least for me personally, especially once I met Rebecca and I understood what she did and kind of started to fill in some of those pieces, the puzzle made sense, like as soon as it got explained to me. Because I think once you understand how critical they are in the research stage and realize that obviously for medical research, there is no capacity to do a lot of this research on a living human. And I think that especially comes into focus probably with, at least for me, it comes into focus when you talk about a rare disease. We call cystic fibrosis a rare disease, but I think that that's maybe a little bit unfair to the rarer ones. Because with 30,000 patients in the US, 70,000 worldwide, that is a pretty significant test bed once you get to the point where you can do, like phase 3 studies on a drug. But there are much rarer diseases that you would have like no hope of testing, real drugs on that population. So having animal models as a possibility is just absolutely critical. Prior to meeting Rebecca, I had no idea the breadth and scope of animals being used in research.
Yeah, that's an interesting perspective. I was just wondering, you're the first, I guess, veterinarian PhD science researcher or like lab animal tech we've had on the show. So obviously everyone's just directly involved in this field.
You're the first outsider.
Yeah. I mean, you said you had a degree in mathematics. So, I mean, that's, something that, my wife's a civil engineer and I just remember looking at her math homework that she had in school. And like, she got to the point where they weren't using like numbers anymore. Everything was just like letters and like sentences and stuff. I'm like, this isn't math anymore. But anyways, so obviously it's still very complicated. So I hope you didn't take offense to like the non science thing. It's just a different perspective is what I was getting at. So it's very interesting. I appreciate that.
Yeah. I think having like a STEM background at all still helps.
Yeah.
For sure. If you would, a little bit, just tell us about the future direction of CF research and maybe the potential to hopefully one day cure the disease. I know we've talked about it a little bit, but just to kind of wrap things up, where the research is going and what kind of hope is out there for the cure.
I think that the end goal for anybody doing CF research is to find a cure for CF. And even though these modulator drugs are doing really great things for patients, it's still not a cure. Some patients can't take them. Some patients have really bad reactions to them that mean that they have to stop them. And then, lung damage and infections can still happen on these drugs. They just sort of slow the process in a way. So there's kind of a three-pronged approach. One is better antibiotics, and specifically ways to target Pseudomonas, because it's one of those bacteria that makes a biofilm, which makes it just very challenging to treat. And it's also very good at mutating. Another thing is ways to reduce the inflammation, which we've talked about inflammation and its role in CF a lot. And finally, the cure would be some sort of a genetic therapy. And I know that there has been research happening on this. I don't think that they have had a lot of success with anything yet. However, I did read an article the other day talking about an mRNA-based therapy, which would be like an inhaled mRNA. And that's just really cool because it shows, how these mRNA vaccines for COVID have started all of this research into mRNA. And that might be the type of drug that finally does cure CF.
Jeff and I were actually talking about some sort of inhaled treatments for COVID just the other day, and kind of, I think, related to that mRNA, the inhaled version. I think that could be definitely be something to watch for in the future. Rebecca, one other question, since you're the lab animal side of this conversation. We ask all of our guests, what do you tell people when they kind of ask what you do for a living? Because some people tend to shy away. Some people are happy to brag. And I think it's just a good way to kind of tell our fellow listeners who are in the field, how to handle some of those conversations.
Yeah, I'm usually pretty honest with people. How much I actually reveal does depend on how much time I have, whether I know the person, what the situation is, etc. If I don't really feel like talking, I'll just tell them I'm a veterinarian. And then usually the next question is something along the lines of, like big animals or small animals? And if I really don't want to explain anything, I'll just say, like a little bit of both and just kind of leave it at that. And usually that satisfies them. But if they ask more questions, or if I'm kind of in a mood to explain what I do, I'll just say that I'm a lab animal veterinarian. And that means that I take care of animals that help out with research. And then usually the response I get is like, oh, that's cool. And that might end it, or they might ask more questions. I feel like the public as a whole is supportive of animal research in general. I mean, obviously there are some people that are very, very against it, but I think that the general public, knows that animals are used in research and just kind of hopes that the animals are cared for and doesn't want to think about it too much. But then when they meet somebody who works in research, they're like, oh, wow, like this person seems like they really care. And then they feel better knowing that there are people that look out for the animals. I mean, I've had like 3 reactions that were not just very positive. So I feel like the benefits of telling people far outweigh any kind of risk of adverse reaction from the person that you're talking to.
Yeah, I guess for those 3 reactions that were not positive, if I were in your shoes, I might take it a little extra offensively. And I'd be like, I am married to someone who is directly impacted by this. Does that ever kind of come into your mindset when you're talking to people? Because you're definitely living a different experience than some of the rest of us who are involved in lab animal medicine.
Yeah, I mean, because I was on this track to be a lab animal vet before I met Cody. So I had other people in my life, who had cancer or had diseases that had obviously benefited from drugs and therapies that were developed through research. But I feel like with CF, just with the recent improvements in drugs that have happened, it's just so obvious how critical research is and how much it's helping this population. So I do feel like now when somebody has a negative reaction to biomedical research, I do take it a little bit personally. And Cody can attest to this. I can get pretty passionate when people are like doing something that I think is going to hurt us, or when they disagree with me so much on that, I'm just kind of like, this is my husband. So,
yeah.
I want to make sure that he and everyone else with CF has access to a cure in the future.
I think you can become very protective.
Yeah. Yeah.
Yeah. I mean, just kind of getting to know you guys now, I would feel a different way about it just because you guys are in this together.
Yeah, for sure. Yeah, but being passionate, I mean, you're passionate because obviously, you love and care about your husband, but you also, I mean, just being in the field of lab animal research, you're passionate. Like you said, you were on this track before you met him. And so you're obviously very passionate and you're caring about these animals that are on these projects. And so, I mean, it just says a lot about the people, like we've said over and over again on the show, that are in this field, that are just truly and utterly compassionate about the animals and about the research and about finding cures and therapies for people that may be suffering from a wide variety of different conditions. So that's a good way to wrap things up. I want to thank again Rebecca and Cody for joining us today on Lab Rat Chat and sharing their story with us. I mean, I learned a whole lot, and I know everyone out there listening will learn a lot and realize the importance of animals in research and how it directly impacts those living with different conditions around the world. So I will again put a link to the Cystic Fibrosis Foundation. That's correct, right? Cystic Fibrosis Foundation, CFF, in the show notes. So go check that out. Try to support them if you can. And if anyone out there listening has a similar story and they want to share their story on Lab Rat Chat, feel free to email Danielle and I at labratchat@gmail.com. We'd be happy to speak with you and give you the opportunity and give us the opportunity to talk to you about how maybe lab animal research and animals within biomedical research have impacted your life or improved a particular condition maybe that you may be living with. So feel free to reach out to us. You can also follow us on social media. We're on all the different social media platforms. So yeah, just check us out. And again, thank you everybody for listening. Rate and review our show, if you will, on iTunes or wherever you can find our podcast and review it. And thanks for listening, everyone. We'll see you next time. Take care.